My name is Reese Garcia. I'm the Senior Manager of Research Advocacy with Fight CRC. And today we're so excited to have Lindsay and Misha from the American Indian Cancer Foundation, Will with Roswell Park Comprehensive Cancer Center, and Eugene with Great Plains Tribal Leaders Health Board join us to discuss colorectal cancer screening in Indigenous populations. As a little background for you all, in October, Fight CRC hosted a general screening discussion with Dr. Caitlin Murphy at the University of Texas Southwestern Medical Center. And the whole goal of that conversation was to better understand screening rates across geography, age, and race and ethnicity. So she really set the stage for us to dive in deeper and explore, the various screening rates, barriers, opportunities, and so forth amongst different populations, and to have these conversations, really looking at those opportunities to increase screening across various communities. This is also a discussion set to challenge our community of survivors to think through what we can do for all affected by CRC. And so with that, we will get started with introductions and bring on our fantastic panel. It looks like we still have some people joining. I have been with Fight CRC for over 3 years, and I am based in Denver, Colorado, and currently I reside on Cheyenne, Ute, and Sioux land. You'll be hearing from my colleague Andy Dwyer shortly, who also resides in Denver, Colorado. So I'd like to focus my land acknowledgement today where Fight CRC's offices are located, and that is in Springfield, Missouri. This is where many of our employees and advocates live and work. And in Springfield, we are residing on land belonging to the Kickapoo tribe. This tribe entered into 10 different treaties with the US government between the years of 1795 and 1854, including the Treaty of Vincennes, the Treaty of Grouseland, and the Treaty of Fort Wayne. These treaties did not compensate the tribes fairly and forced thousands of indigenous inhabitants to leave their lands without their consent. So it's necessary that we honor these historical beginnings, and as inhabitants of this land, we recognize the importance of indigenous culture within our communities. Today, we honor those that resided on the land that we gather, live, learn, and work on. And I'd like to thank everyone for joining us today to have these necessary conversations. With that, Mike, would you like to introduce yourself?
Thank you, Reese. I'm Michael Marositz. I'm the Patient Education Manager for Fight Colorectal Cancer. I'm located in Newport, Rhode Island, and I acknowledge that the land I currently occupy on Aquidneck Island in the township presently referred to as Newport, Rhode Island, is sacred land to the Narragansett tribe, who have been stewards of preserving and protecting this island for thousands of years. This land was sold by deed contract on March 24th, 1637, by Chief Sachems Canonicus and Miantinomi of the Narragansett tribe to a Mr. William Coddington, Judge Magistrate of Rhode Island and Providence Plantations, for a nominal sum without recompense for future agreements to return the land. I personally recognize the significance of this land acknowledgement and the efforts to preserve tribal heritage by current tribal leaders in this area, including the Aquidneck Island Intertribal Indian Council. My work with Fight CRC and our partners, the American Indian Cancer Foundation, Roswell Park, and Great Plains, represents a commitment to solidarity with the indigenous tribes across the continent, supporting grassroots health and wellness initiatives in this discussion and beyond. Thank you for this opportunity to work together.
Great. Andy, would you like to introduce yourself?
Hi, everybody. I'm Andy Dwyer. My legal name is Andrea Dwyer, so nice to meet everyone. I am the advisor for Fight CRC for their colorectal cancer research and patient education aims. I am on faculty at the University of Colorado School of Medicine and School of Public Health and Cancer Center. So in Denver, where I reside currently, and in relation to my rural Colorado roots, currently where I live, they reside in the traditional territory of the Ute, Cheyenne, and the Arapaho tribes. I'm also recognized the 48 contemporary tribal nations that are historically tied to the lands that make up the state of Colorado, as well as my own rural community. This land is sacred to the Arapaho tribe and was forcibly taken from them in 1851 in the Treaty of Fort Laramie, which represents an unsustainable purchase for the tribe that left them without ability to reclaim their land. I acknowledge the name of my hometown and in honor of the Cheyenne tribe, my hometown Cheyenne Wells, but the Cheyenne tribe was a very powerful, resourceful tribe of the Great Plains who fiercely resisted white encroachment of the native lands. And in my work of cancer prevention, I honor and celebrate all of the great tradition and tribes of Colorado and beyond, with my mission to maintain and restore health with the populations I serve.
Thank you, Andy. Misha, I'll hand it over to you for your introductions.
Hi, Bonjour, Misha Deshnikaz. Hello, everyone. My name is Misha. I'm the Cancer Equity Coordinator for the American Indian Cancer Foundation. I'm an enrolled member of the Bay Mills Ojibwe Indian community, and I'm also a descendant of the Blackfeet Nation. I live here on sacred Dakota land in Minneapolis, Minnesota. So Minnesota is the ancestral and current homelands of the Dakota people. So they have been here since time immemorial. In Minnesota specifically, we have 4 Dakota communities and 7 Ojibwe reservations. The Dakota tribes in Minnesota include the Lower Sioux Indian Community, Prairie Island Indian Community, Upper Sioux Indian Community, and then the Shakopee Midday-Wankinton Sioux Community. I am super grateful to be here with all of you, as well as the ancestors, tribal leaders, and relatives in our communities who are caring for one another. Miigwech, and thank you.
Thank you, Misha. Will, would you like to introduce yourself?
Sure. Thank you for having me today. Nawi Scano. Hello, I'm glad you guys are well. I acknowledge today that Roswell Park Center for Indigenous Cancer Research is located on the ancestral lands of the Onondaga, otherwise known as the Great Hill People or the Seneca Nation. We are the keepers of the Western Door among the Six-Nation Haudenosaunee Confederacy, otherwise known as the Iroquois Confederacy. We're protectors of encroachment of the sacred land we call home and the right to free will. We continue to fight for our sovereignty, maintain our cultural values and our health. Our lands are protected by the dish with one spoon wampum agreement to share resources, the land, and take only what is needed. Today, I extend my gratitude to all the current Seneca who share their land with those who are non-Indigenous. I express pride in our elders who remind us to maintain a good mind and not stray from our traditional values. I honor the teachings of my Seneca ancestors by reminding the world of our contributions to science, medicine, and healing. Thank you.
Lindsay, would you like to go?
Sure. Thank you for having me here today. My name is Lindsay Petrus. I'm the Cancer Program Manager at the American Indian Cancer Foundation. So Buju Anin, the Anishinaabe prophecy Gitchi Manadu, the Great Spirit told the Anishinaabe people to move west from the Atlantic coast until they found food that grows on the water. This branch of Anishinaabe, known as Lake Superior Chippewa, found wild rice near the Chequamegon Bay on the south shore of Lake Superior. I, Lindsay Petrus, work and reside in northern Wisconsin on the homelands of the Bad River and Red Cliff bands of Lake Superior Chippewa Indians. After a disastrous attempt at removing the Lake Superior bands, which resulted in the Sandy Lake tragedy, the government agreed to set up a permanent reservations in Wisconsin. The Treaty of La Pointe was made with the United States and signed in Madeline Island on September 30th, 1854. Today, the band is reclaiming their rightful land and ensuring that their culture is preserved and practiced. I'm humbled and honored to be here today. Thank you.
Thanks, Lindsay. And Eugene?
Palmedakiapi, Eugenie Machiapielo, Lakochaje Makpiawa Hunkuze. Hello everyone, my name is Eugene Gallego. My Lakota name is Makpiawa Hunkuze, which is cloud staff. For me, I am a part of the Ogallala Lakota Sioux tribe, as well as the Kuli Chasha, which is the Lower Brule Sioux tribe. And we are also a part of other tribal reservations that are the keepers of the Black Hills located in South Dakota. We are the protectors as well through the 1868 Treaty of the Fort Laramie Treaty. Thank you, everyone.
Thanks, Eugene, and thank you all for those wonderful introductions. And again, thank you to everyone that's joining us today. I'd like to remind everyone that this is a conversation, so if you do have questions or comments for the panelists as we really dive into these discussion topics, please feel free to put them in the chat or come off mute to discuss. We'll also have time during the second half of the conversation to ask more specific questions aimed at our communities that are joining us today, and we invite you all to participate. So with that, I think we can dive into our first conversation topic. And Mike.
Thank you. Yeah. So as Reese was just saying, we really want this to be an experience that is really engaging. You know, we have so many webinars these days. This is an opportunity to really have a conversation at a time when we're all at home and that's difficult to have that. So beginning, we're going to introduce some topics and ask some questions of our panel to help set a foundation and ground level for all of us to work off of. And once we've made some connections over those topics that are really going to focus on colorectal cancer screening, some data behind it, and some resources that each of these represented organizations have available to people, we'll open it up even further. And I'd really encourage you to get off mute, to get involved, get engaged, and ask those questions of our panelists so that you can really get some real insights that are going to lead to action that you can bring home with you after this conversation is over. So starting out and really opening it up to our panel here, so hoping that you all could share some information or data that you have on screening rates for your populations that you work with, and really focusing on, what is some things about early age onset and family history and other factors that play into how you're able to address screening rates in each of these communities. Thank you.
I don't mind stepping in and tackling that question. It's a very complicated question in our communities because of data sovereignty. I am currently working on a Screen to Save colorectal cancer initiative through the National Cancer Institute, working with our Indigenous communities. And on paper, it seemed fairly straightforward to obtain data and statistics from our local Indigenous communities regarding colorectal cancer rates. If I was to go to any hospital or primary care office, I'm sure I could obtain those numbers fairly quickly. If it wasn't done in indigenous land or within a tribal community, I should say. And what I found was that in our communities, we do not have data. We don't have any access to it at the local, state, or federal levels. And this provides a challenge because we don't have a baseline. We truly don't know what the actual current rates are of colorectal cancer screening, for example. And we certainly can assume that there's room to improve and there's room to intertwine some of the community engagement and education programs that we're doing, but we really don't know. And I know that other communities do have better data sets than we do, but for us, it's an ongoing struggle to actually know what our baseline is for all types of cancers and all chronic diseases as well.
Thank you, Will. And so, if we can see that this is probably, if it's happening with you, it's happening across the board. So what are some barriers to being able to get that data that your organization and other organizations are looking at overcoming?
Some of those barriers are trust. For our communities, it's the trust in the medical system. There's different terminologies for how we view the medical system. Sometimes it's referred as allopathic medicine or Western medicine, but there has been historical distrust or historical traumas involved in both research and medicine as it relates to the Indigenous communities. So that's passed on from generation to generation. And we work hard as an Indigenous Cancer Research Center to try to increase the transparency about research, for example, specifically research and data sovereignty specifically. So I think trust for us is really one of the primary barriers. And I think I can speak for some of the panelists today that transportation, location to care oftentimes provides a significant barrier to any type of medical care, any type of medical supportive therapies. I think that distance oftentimes plays a significant role. And we know that statistically that your location from a cancer center or screening center or hospital often dictates the outcomes, whether or not you are, you prevent cancer, you screen for it early and detect it early, and also quality of life following cancer treatment. We know that earlier intervention usually means better outcomes, typically. And because of these very difficult but obvious barriers of transportation and trust, relationship with your provider. Oftentimes providers have a strained relationship with their Indigenous patients because of competing cultural values. That often plays a significant role as well.
Great. Yeah, do any of our other panelists have anything to add to that?
I can add a little bit to that. I think some of the unknown, that could be a barrier. It's scary not knowing what that result will be. And also the process. What is it? What does the screening look like? What's going to happen to me? Not understanding the process, I think, is another barrier. And so those are two barriers that kind of come to mind right away.
I think, so we had talked a little bit about data earlier. So some of the data that we do know is that colorectal cancer is the second most common cancer among Native people. As Will had pointed out, that data looks really different for each one of our tribes and our other Indigenous communities and villages. And it can be really hard to obtain that data for many reasons. There's a lot of really good webinars out there on data surveillance in Native communities, but part of the lack of data that we see is due to just some of the cancer registries not having like a uniform or centralized location for all of this information. And so what that does is to really complicate how we find information on our relatives. And then I see in the chat here, some other barriers are competing cultural values. And I also see someone had said that building relationships is key. So I think a lot of us know that, as Will had pointed out, trust is a huge thing. So building rapport is really important for many of our relatives, as well as just making sure that there's a level of cultural competency or cultural humility. I think the idea of competency brings up this question of whether or not you can like obtain or become fully fluent in something. But I think our ancestral knowledge is a lot more nuanced than just like crossing off a checkbox. So, the question.
I see Cassandra had asked me to clarify what I meant by competing cultural values. So that's a difficult question to extrapolate, but I'll do my best. So I think that in many contexts, the specialization of medicine oftentimes competes with holistic Indigenous values. We know that our elders often teach us the power of the spirit and really to respect and honor the land and how these all contribute to our health.
And I do have kind of a follow-up question to all of you about that trust component. So yesterday I was on, or I believe 2 days ago, on a webinar for the NCCRT, and one of the presenters focused on the fact that one manifestation and accepted manifestation of patient blame is the undue focus on patient mistrust, and that could be a potential driver, to these racial inequities. So I'm curious what your response to that is. We talk about trust, but is trust really that manifestation of, racial injustices as it is? I mean, I'm curious what you all think about that statement.
I personally think that that is a big part of it. If we have seen just throughout history, our relatives and our ancestors, our elders being treated a certain way, it can be really difficult to want to operate in those spaces when we don't feel safe. Hopefully that kind of answers your question. I don't know if anyone else wants to add anything. Eugene, how about you?
So just to kind of touch on that, there had, like what Misha talked about, historically, there has been that mistrust, and we've seen that periodically within our communities, even up until now. Everything going on with the movement, with the Black Lives Matter, with everything with the Native American perspective, a lot of people have that mistrust, and that has been historically, through generational trauma that has been passed down. So it's no wonder that you see that nowadays, a lot of people holding back from providing that type of information or data. So some of that information can be skewed.
And it could certainly be challenging looking to, like, how do you build those relationships that are going to build that trust? So who are some health promotion partners that you've worked with in, industry and everything like that can help maybe bridge some of these gaps for people and be able to help inspire some trust within, a system that's not directly tied to your Indigenous communities?
So yeah, that's a really good question. Typically we have in our communities, in order to push that awareness forward, we have some of our local leaders, we have some of our community leaders who may not be directly involved in the medical field per se, or the research field, but they are able to provide that bridge between, the unknown and our community, or our community knowledge. So we actually partner with a couple organizations within our communities who teach, for lack of a better word, Misha, I really like perspective on cultural competency, but for lack of a better word, that teach cultural competency to our providers. And I'm speaking on behalf of my community, form a way of of creating that trust. And I can tell you that from even for myself, working within my own community, that ways things we can do is listen. And I know that's a skill that I think a lot of us, including myself at times, probably lack. But I think listening to the needs of your community, it's not an overnight solution, but it certainly helps create a bigger picture, and also opens a door for empathy, so we do understand what those needs are and what those wants are. And once an individual can convey that to you, most times you develop trust naturally. It is organic. A lot like this conversation we're having is it's typically very organic, regardless of race or your ethnic background. I think that if we can open our ears and be open, which sounds very esoteric and maybe not very easy to obtain, but it is a skill. It can be taught. You can learn it. And I believe just listening is a very simple way we can start to enhance trust between all people.
And just to touch on that, from what I've noticed within the tribal communities in the Great Plains region, which covers North Dakota, South Dakota, Nebraska, and parts of Iowa, a lot of it has to deal with community champions. So if you're able to have a community champion with a partner that isn't related to the tribal community, that helps bridge that gap or that barrier that's in between. So for us, I know that we did with the Great Plains Colorectal Cancer Screening Initiative, we did quite a bit of work with the American Cancer Society, the North Dakota Colorectal Cancer Roundtable, and a lot of them have worked with tribal communities and organizations such as the Great Plains Tribal Leaders Health Board. So they were able to work with us closely and bridge that gap. So if you have those community champions, those people that will work closely with those organizations that are willing to put in the effort to bridge that gap, I feel, it's going to have a better outcome in regards to that.
And just to touch on that too, Eugene, I like that. As a nurse, I think it's our responsibility to seek those answers and to kind of bridge those gaps. And so thinking about that, having a nurse as a champion to really promote CRC screening and really be that voice and kind of that bridge between the provider and the patient, that's our responsibility. So kind of speaking from that aspect too.
Excellent. And thank you for bringing that around to CRC screening, because I think that definitely, as you find, resource champions are paramount to our efforts at Fight CRC to really create, advocates and ambassadors for colorectal cancer that are really engaged and involved in their own cultures across the board. So having that exist specifically, within tribal communities has got to be essential. So what kind of messaging, what kind of resources or tools should be in the hands of these champions to help guide people to get screened, to get involved with their doctor in talking about colorectal cancer?
Hey, just to touch on that, so we've known this for quite a while. We've known that individuals, members of tribal reservation communities, they share a different type of aspect or thought process on this. So what the Great Plains Colorectal Cancer Screening Initiative was developed informational, educational materials to be dispersed to these communities. And one way that we did that is involving ourselves with those communities. So even though I'm Lakota myself, I work with Turtle Mountain Band of Chippewas. I got to be out in that community. I got to know, their cultural differences and tailor different type of messages that fit best for them. So a lot of it has to deal with the organization that is putting out those information materials. You got to culturally tailor them to fit the needs of that community itself.
We have a community advisory board that really helps guide a lot of our initiatives, colorectal cancer screening initiatives. And so whether it be an educational material, PowerPoint presentation, an infographic of some type, or a community advisory board, which are just community members directly from the communities we intend to serve, they give us insight about whether or not we're on the right track or we're not, whether or not this is a poignant message or we're missing the mark. And we do sometimes miss the mark. And as I've learned through my work and listening to our communities who give us really, really important messaging, is there's often too much going on, and so I think what we do to really enhance that message is to simplify what we're trying to say, and incorporating specific cultural dynamics. And I know that everybody on this panel will agree that every Indigenous community or tribal community in this country is different. Even among the Six Nation of the Haudenosaunee are very different. As a matter of fact, at one time we were all warring with one another and fighting constantly, and that's where the Great Law of Peace comes from. As we decided that's probably not of a good mind. And so, in order to be able to survive colonization, we probably need to come together. And those type of messages, individual to our community, really should drive a lot of the educational materials that you're trying to really enhance any of our health education efforts.
Great. And then, no panel discussion or webinar these days would be complete without bringing up COVID in some way or another. And we know that certainly that a lot of Native and Indigenous populations across the United States are disproportionately affected by COVID in their rates of infection. So, knowing that there's many health disparities that exist that are tantamount to colorectal cancer, what are your different agencies and organizations able to do to help keep momentum going on things like screening and colorectal cancer prevention during a time when we're so reactive to COVID?
I hope I'm not jumping the gun in here and, cutting in front of anyone, but for us, the Great Plains Colorectal Cancer Screening Initiative, since COVID hit, and it hit such a large population within the North Dakota, South Dakota region, primarily in the United States. For us, what we done and what we thought about was a process. Now, this came to light with the Center for Disease Control, along with other organizations, what ways to counteract these. So one way that we've developed and one way that other large organizations are trying to implement this screening process is through the postage and mailing. So that's one of the things that we do with our subawards. Since we do grant these subawards funds for their initiatives, their evidence-based interventions, their implementations, one way that we counteracted that was implementing and offering that for our tribal subawards. And we cover quite a vast amount of tribal communities. We cover 18 tribal communities within the Great Plains region. So we offer that across the board through these subawards. We offer that, if you do need funds to cover these, we're able to cover that for the postage and mailing. And a lot of these communities are taking that into consideration and actually doing that.
ACAF has also been working on that as well. So we're working with some of our subawardees with postage as well, Eugene. So that's a really good point you brought up. And then also some other things we're doing to support is we just came out with a PSA on screening to continue your screening. Cancer doesn't stop. So we did a PSA. We also are working on a PSA for any tribal or urban community that wants to do one. So we're working on a 20 to 30 second PSA for them, for their own community, tailored to their community. So we're working on that as well. And then one other thing is we just came out with a new infographic supporting people with, getting screened for COVID, and then also doing, following through with their screenings. So, and I'll let Misha kind of add in here too, but those are some of the things that are off the top of my head.
Yeah, so I think in addition to some of those activities that ACAF is doing, we also work with a few urban Indian health programs throughout the country to work on colorectal cancer screenings. And so we go into these communities and really dialogue with them about kind of what their community is looking for, what they need. And we kind of make sure to figure out what they need and then kind of do some of the work for them so that they can focus more on other things. So right now what that looks like is a lot of like resource development. So we have client reminders that are very easily accessible. We have different kind of informational care packages, I'll say, that we send out to different clinic partners that are interested in getting some of these materials on CRC out to our communities. Yeah, those are just a few things I'm thinking about off the top of my head right now.
And awareness months. We do awareness months throughout the year. It's not just for CRC, for breast, cervical, survivorship. So we're really trying to support these clinics from afar with like social media toolkits and things like that. So yes, that, adding on to that, Misha, yes.
Absolutely, Lindsay. So one of the things that the Great Plains Colorectal Cancer Screening Initiative did was extended that colorectal cancer awareness month, but we extended it out to all of the subawards, through this was something that was brought up through the Center for Disease Control. What ways can we bring that type of insight to our tribal communities? And one way is to extend it out through the whole year. Because as the pandemic hit during the month of March, which is colorectal cancer month. So one way is that to counteract that is to kind of push that out through the whole entire year.
I'll go ahead and answer the question that Andrea had. I'll just recite the question and I'll try my best to answer it. We are seeing colorectal cancer impact all ages of people, more and more young, but still mostly older people. How is the messaging to younger people and elders the same or different? And I'm sure ACAF and Eugene could also chime in with how they might be approaching this. For us, we're a relatively new center, so we're just establishing our base with all our entire community. So we're still trying to figure out what the best way to reach our folks are. And we know that depending on age, you're probably going to get your information from different sources. And so we remain very flexible in terms of how we disseminate information. So we mail items out, but we also have a fairly strong virtual presence similar to ACAF as well. And we know that we know that we're probably not going to reach a lot of young folks by lecturing about the importance of colorectal cancer. But if we can create a more dynamic and resilient based message to our younger folks, that they may be more prone or opt to actually listen to what messaging we're trying to convey. So we also have a podcast, webinar series as well, which is more for our maybe academic or health conscious audience, but also a podcast where we specifically target our youth in our community with topics that we feel the community is the most interested in. And we get a lot of feedback. All of our team members live in our communities that we work in, so we get instant feedback from our family members, from our relatives, or from our neighbors about what issues are most concerning to them. And I think with enough work, and if we listen enough, we can start to stratify what issues and what demographics are really the most important. And we know that, based on my work of providing colorectal cancer screening, it's not exactly who's 18 or 20 years old, where somebody that's 40 maybe in that stage, that stage or that transition where they're starting to maybe think about their mortality a little bit, and so screening may be not a bad idea when you're younger. I think those messages have to be, they have to be tweaked quite a bit in order to reach your audience. And I know one of the ways that I found to reach an audience, regardless of age, is to promote resiliency, cultural resiliency, and messages of pride through these discussions. That seems to attract a lot of interest in folks who otherwise may not have interest in cancer screenings.
And just to touch on William, one of the ways that our organization has counteracted this, especially with the younger population, is actually being out into the community. So we've got quite a requests from tribal communities requesting the Great Plains Colorectal Cancer Screening Initiative to be a part of any type of health event. A lot of these health events have included a lot of the younger generation. And one of the ways that we've utilized a tool that fits best for these tribal communities is a bigger visual. So one way that we did that is implementing a inflatable colon that we brought up into the community. And bringing this type of learning method, this learning tool has, with the data that we aggregated, we've shown that there is a increase in knowledge with the younger population, with the pre and post that we implement. So we typically will survey whoever is going through the inflatable colon. We'll make them take a pre-test and then a post-test afterwards. Now, what this data reflects is that there has been an increase in knowledge reflected into it. So it's shown that some of these younger generation, especially with any type of schooling events that we bring this role and colon to, especially in the state of North Dakota, because we've been seeing a spike in the younger generation with colorectal cancer. So it's shown that a lot of these younger students are understanding this, what colorectal cancer is, because a lot of them don't know. They don't know what a colon is, but we're able to educate them through that process, what colorectal cancer is. If anyone has a family history, what is a polyp, those types of things, we're able to include that with the education that we provide in each community with the inflatable colon.
I will add a little bit about kind of what ACAF does. So we focus our messaging kind of for CRC screening as a like modern ancestral way to focus on prevention. So we know that our Indigenous lifeways work. So we talk about screening as part of the work of an ancestor today is to get screened. And then also I think it's really important to note that taking a look at or thinking about our family dynamics and just like how important our relatives and our communities are to us is really important when discussing with anyone from any age. So I know as a young person myself, I'm definitely thinking about like family history in relation to colon cancer. And so we're kind of making sure to have some of those conversations, like as Eugene had said, talking about family history. Here at ACAF, we have a family history tree that we really like to emphasize or encourage use of in our communities. Yeah, and then also another thing that I thought of too was that many Native communities consider time to be very nonlinear. And so in that way, like there can be an emphasis on how what happens today or what happens in your young body today is really important for tomorrow. But in this like collapse of time or this like Indigenous cosmology of time, it's like possible to kind of like link this interconnection of the body from one point in history to the next point in history.
Misha, I have a follow-up question for you. So I know that ACAF provides some fantastic resources for other cancer types as well. And so do you find unique challenges as it relates to the colorectal cancer screening discussion compared to like cervical cancer, for example, or are you seeing similar challenges in that messaging across cancer types?
I personally, I don't know if I look at it as a challenge. Maybe that's it. So I'm going to say no. I don't really see some of those challenges, partly because how we understand things here at ACAF is that everything is very interconnected. And so a lot of these messages are kind of able to be tailored across, different types of cancers.
Do other people find about the same thing in their organizations as well?
Yeah, I think so. And like I mentioned before, that I'm going to go a little bit off script since we're in the spirit of having an organic conversation. I'm going to go a little off script here.
Please.
One of the messages, or one of the ideas that most Indigenous people, and when I say Indigenous people, I hesitate because I don't want to overgeneralize and speak on behalf of somebody else or other communities that I'm not aware of. But I do know that we understand the body, we understand the whole person, I think better than most. And I think one of the things that ACAF does very, very well, and I'm familiar with their resources, we actually rely on them heavily in partnership and using their resources, but it's the centralized message that what we're doing for ourselves is going to affect 7 generations ahead. And regardless if you're a young person or you're an old person, that message resonates with you. It's been taught to you in some way through your community, through your family, through your relatives. And so that's a really critical, I think it's a really critical concept when we're talking about some of the challenges we face with, tailoring materials to different people, different ages and different demographics, is that I think that the successes that we've had in being able to disseminate information, specifically during the pandemic, when people I think are very fatigued and think they're wiped out, they're stressed out. And to add colorectal cancer screening statistics and initiatives and programs is it's not an easy sell. And so what I believe that has worked for us in Western New York and listening to our communities is that they're a little tired of hearing that Native Americans are more susceptible to cancer and diabetes and COVID-19. We understand that. And what I think what message is really providing a breath of fresh air is that within our own respective communities, there's answers to these problems. We all have the capacity to heal. And I think that regardless of age, that's a message we can all understand, is that if we are given the right tools and we choose to accept it and take responsibility to a certain degree, that we can find the answers to our own health within our communities and our own knowledge, our ancestral, traditional knowledge. And by weaving that message into all of our initiatives and all of our different types of media that we use to convey messages and education, we find that centralized message really helps tie things together. And regardless of whether we're talking about colorectal cancer or we do work in clinical trial education as well, or any other cancer types, the centralized message is that the whole person matters, not just the part. And if we can piece the pieces together and focus on the entire individual, from that we can cultivate I think a very poignant message that a lot of many Indigenous people understand regardless of age. I hope that makes sense. But essentially, I think that those core values is at the heart of every community. And when we are disseminating information, we have to keep that in mind. If we don't, we miss the mark, and whatever messages or attempt we're making to listen or help the community fall by the wayside. I've experienced that myself with a couple failed initiatives that didn't get very much attendance or participation because after evaluating those programs, I realized now we had not focused on some of the core values that are so important to our community.
Yes, thank you for that insight, Will. Certainly, it's you gotta sometimes try and put out there and use that voice and understand what's going on to really create those programs that are going to have that lasting impact. So thank you for all of that. And also thank you for bringing up family history as you all have in different ways, because November is Family History Month. So this is a good time to bring awareness out of all of that, and especially having such a rich context for that you're able to have is something that's extremely important. So for everyone on this call now, think about that this year as we hopefully can get together in some way or another before the year ends to think about what your family history is, be aware of it. And as we've discussed here, certainly thinking about how just a lack of awareness is one of those biggest barriers. So get that information out there. That's, I think, set us up with a really great foundation. I want to make sure we're able to have everyone who's on here ask their questions and have a discussion and take advantage of the fact that you have these wonderful panelists available to you to get some information that you can take back to your own individual practices, organizations, and interests that you have in colorectal cancer screening. So I think it maybe just to kick us off, to get us started, I'm going to put this out there to everyone out there in the audience. What has made it difficult for members of your community to get screened, and what has been successful? So both challenges and successes. Hopefully your panel can help provide you with some insight and some ideas for resources to help encourage that. So please, if anyone feels free to write in the chat or get off mute and ask some questions.
Mike, maybe while everybody's getting some questions together,
Sure.
I had something that was from, I think, I think I said policy because I've already jumped to my question, but or to one of the things I'm thinking about is strategy. I think that the idea about data and the difficulty in terms of ascertaining data and using data within certain tribes, populations, it's something that's been a real issue, I think, since I've been working in colorectal cancer. So I guess to the folks that are on the panel today, I did hear the sort of issues, of course, around mistrust and thinking about how we share and how we gather data and information on folks. But because Fight Colorectal Cancer does a lot around the policy initiatives, I'm just wondering, is there anything in addition to, I think, really sort of talking about how data can be used and how it can really elevate for good? Are there any other policy drivers or any other sort of attributes of sort that could be helpful in getting better data and resources to your communities in terms of gathering it as well as giving back to do good things with.
Hey, can I touch base on that? So one thing that we've noticed with our tribal communities in the Great Plains region in North Dakota, South Dakota, Nebraska, and Iowa is that a lot of these IHS, these tribal facilities, are entering data improperly, and it's not a good reflection on the actual work that they're doing. You know, and this was all discovered through some of the provider assessments that we did with these communities. We went to these clinics, we went to these Indian Health Services facilities and discussed with them. We've had a checklist. We've went through different action items, and we found that a lot of them have seen the data that we showed them on colorectal cancer, and they're looking at us like they're puzzled, like that's not accurate. So what it stems from is the entry. Why is this entry being entered improperly, and what can we do about it? So one of the things that Great Plains did was that we've talked to a champion in a community that is specific to eye care through EHR, through anything with entering GIPRA numbers through the government's Performance and Results Act. How do they enter that in correctly on a facility basis? And we were able to cover all of those questions, those types of barriers that were counteracted through the process of entering this information. And we provided that through our whole communities in North Dakota, South Dakota, Nebraska. So in attempts that we've uploaded that through our website, and we've recorded that session. So if anyone in the community, in the region, has any type of difficulties entering this into EHR, eye care, whatever, let me know, and I could be able to provide some of that resource for you.
To go off of that as well, so one thing we've noticed at ACAF and working with our clinic partners is a lot of times they have to refer people out for colonoscopies. So when they refer people out for colonoscopies to these hospitals, they're not returning those results back to the site. And so that loop is missing. And so that is something that we've come across, and we're trying to help these sites collect that information to make sure that, you know, that's being followed up on, and how we can help them work on their systems a little bit more to kind of build those partnerships with the hospitals too, where they're able to log on to their EHRs as well to get those results and put them into their system. So that's something we've been working on. Another thing that Misha and I know that's been on the top of our minds is misclassification of race. That's another thing that we've been noticing quite often is that's not filled out completely. And so people aren't being counted for those screenings and just to be counted in general. So those are two things that kind of came to mind when we were talking about this. So.
Hey, just to touch base, sorry, I don't mean to jump the gun again, but with Lindsay's response, you know, one of the things that we've done, and we've noticed that with our tribal communities, is that we're not getting a good return with the FIT testing, the FOBT testing. So one of the ways that we counteracted that was implementing any type of reducing structural barriers with evidence-based interventions. So one way that we did that was implementing a gas card for these patients. You know, if you were to come in to get a FIT test, an FOBT test, what you would receive is a gas card for your transportation over there. And then when you return it back, some of these facilities will also give back another gas card, you know, for your trip back. So that's one way that we've counteracted that in reducing structural barriers for patients that are wanting to get screened.
Great. Looks like we had a question come in from Debbie, or really more of a comment/question here, is talking about access to any type of healthcare is sometimes governed at the financial status of each specific tribe. and working with the colorectal cancer community that's specializing in ostomies, IHS does not stock ostomy supplies. So perhaps pulling from that, what can we look at as far as, what we would call financial toxicity, or an idea that finances can be a barrier for people? Fit test and things like incentives for gas cards can be a great way to help connect that. But then what can be done, or what can be talked about around some of the more expensive testing if it's not being covered by insurance?
So just to touch on that, we do have some tribal facilities in the Great Plains region that are 638 rather than Indian Health Services, which means that the government runs that facility. With 638 facilities, they have the I guess the leisure of having their tribal community, their tribal facility run that healthcare facility. A lot of them, some of them, I should say, have implemented the Cologuard. Now, Cologuard is a lot more expensive, but because they are 638 ran, they're 638 funded with their tribal community, they're able to cover these costs. So that's what a lot of them have done.
And just to give you maybe some idea of the amount of money that's allocated per Indigenous person who is receiving care from an IHS clinic, and this is data that might be a little dated, and I'm actually reciting some of the work of my director, Dr. Rodney Herring, but typically those who are incarcerated receive more money essentially for their medical care than an Indigenous person receiving care from an IHS facility. In order to make a lot of these changes, you need sufficient resources, and I think Eugene made light of that. Is that compared to a lot of IHS clinics, the resources may be more favorable, and that's really a problem for trying to really improve changes at the level that we're talking about here, which is improving colorectal cancer screenings, which essentially want to improve that outcome of higher colorectal cancer rates. Is a very, very significant outcome, which requires significant resources. And especially when we talk about location from cancer care facilities or screening facilities, that's a significant financial barrier for a lot of people. And if an IHS, and oftentimes these IHS facilities, to their credit, are often overburdened.
Yeah, I mean, it certainly would stand out to me that, as we talked about champions before, a champion who really understands how to navigate in the system could be someone who's really effective at helping people get connected to screening and everything like that. So hopefully we'll continue to see more training and opportunity for people to understand more about that goes. Because we can talk about policy, and there's a lot that needs to be changed with it, but ultimately, what can we do now with what your communities have at their disposal to really be able to address and work within the system that exists currently? So maybe you could perhaps, as what was example there, ostomy supplies and things like that, to keep it though on screening, are there any other resources or any other ways in which people are able to address this from that perspective?
Yeah, I just wanted to add, I think that this is an underutilized thing in most clinics and hospitals, is a medical benefits specialist. They are worth their weight in gold. So when sites invest in them, they can get patients signed up for insurance. And that's huge. That's one of the biggest things. So I can't say it enough. They're very important. They're a very important piece of the healthcare system, is having somebody available to work with patients, get them signed up for the right services, get them connected with the right insurance to get those supplies. If it's not being provided to them, we can get it another way. So really having them have somebody that can be kind of an advocate for them with health insurance. I was in a American Cancer Society meeting today, and there was a quote, and I just want to put this out there, and it just was really powerful to me. It said, "If we are doing our jobs, we shouldn't be perpetually serving the underserved." I'm going to leave that right there.
Thanks for touching on that, Lindsay. Another thing too is, and this is something that within my region that I'm seeing a big difference in, and it has to do with Medicaid expansion. You get in two states. North Dakota, South Dakota. One has Medicaid expansion, one doesn't. We're seeing in North Dakota that, you know, when they do have that Medicaid expansion, they're seeing a lot of assistance, a lot of help when it comes in regards to colorectal cancer screening. So I can't say the same for the tribal communities within the state of South Dakota as I can say for the state of North Dakota. So what I would suggest is people that are looking for that additional type of resource, that type of funding, look at your state, see what your state has implemented on a state level, and see what is allowable and accessible for that.
Great, Eugene. Thanks. Any other insights on that? And again, anyone out there as well, please join in on the conversation if you have some ideas or resources around how you've seen people in your community get connected to these resources.
We've been working with a local, I believe it's a statewide organization broken down at the county level called Cancer Services Program of Western New York, and it's broken down into county or several different counties. And what they offer is essentially free colorectal cancer screening to anybody who's uninsured. Now, I've talked to a lot of people, and so far I haven't met too many people, if any, that aren't insured in some way. But nonetheless, they do exist to fill in some of those gaps for folks who don't have, and I do know people that choose to not utilize IHS facilities, and they may find themselves out of work suddenly, and then they're uninsured. And so there are ways that our team, specifically Center for Indigenous Cancer Research, attempts to link people up to those services. One of the ways we've identified, and this is actually a problem that our communities have helped us identify through our research, is that once an individual leaves their respective tribal clinic and they go to, say, Roswell Park for some type of cancer screening or cancer treatment of some kind, they get lost in the system somewhere. Up until 5 years ago, Roswell Park didn't even have an identifier for Indigenous people. It didn't exist. And so we've had to create that. And so up until that point, we really didn't have an efficient way, and we still don't have a very efficient way of identifying Native American people. And if we don't have a way to identify them, we don't know who exists and how to serve them and what resources they need. So what we've done is we've applied for this is a center-wide grant to fund patient navigators. These patient navigators will actually work directly with the tribal clinics. And for those who are of screening age or going through the process of colorectal cancer screening, that navigator will help them through the process, whether it be insurance, supplemental insurance, whether it be employer insurance, IHS, patient care, or they're actually traveling to Roswell Park for services. This person would travel along with them. So if there are any gaps or voids in services or along that cancer care continuum, that patient navigator can identify that and help that person identify the resources instantaneously versus it being post haste. And we see this oftentimes after somebody leaves a tribal clinic. So it's a long way for most of our folks from their respective communities to a cancer treatment center. It's very overwhelming. Even our local hospitals, it's very, very overwhelming experience. And so in identifying that as a problem, we realized, well, there's a lot of resources that are not being utilized. What's the best possible way to link them up to resources along their cancer journey? We realized that it's necessary to have community health educators like myself that we certainly serve a purpose, but we can't be there. We can't be there for that person during their journey, whereas a patient navigator can. So we are hopefully going to be funded for a slew of patient navigators that will both be hosted at Roswell Park and in our respective Indigenous communities. So we can identify those people and we link them up to the proper type of resource, regardless of what that service is, whether it's behavior, whether it's financial services, whether that is linkage back and forth between the cancer center and the tribal clinic.
Great, thanks for sharing that, Will. And I say as a larger overarching organization at ACAF, are you seeing similar things happen with comprehensive cancer centers and things like that you work with?
Yeah, I think I'm not going to speak for Misha, but I see that. And so, I mean, it's just, it's tough out there. I don't even know. I mean, yes, we see that. I mean, it's frustrating, and we are seeing that issue. Misha, do you have anything to add?
I would just reiterate and agree with Lindsay that that's definitely what we're seeing. I think one thing that I think a lot of people in our communities know is that we take on one role, but we end up filling many, many roles. So often what I see is that, for instance, like youth work professionals will often be playing the role of the community health educator when that's not necessarily their role. And as we know, like screening begins at 45. Of course, that's different if you have a family history or symptoms, that kind of thing. But often we'll just see these youth workers trying to impress upon all community members, all relatives, that they need to get screened. And so I think some of it is just kind of empowering our relatives, these champions, to continue talking about CRC in whatever capacity it is, and knowing that the actions that we kind of take to go above and beyond really do serve and love on and support these 7 generations.
And just to kind of touch on that with the access to care, when it comes to screening, and this is something that I had no idea when I was first a patient navigator for the Colorectal Cancer Screening Initiative, is some of these facilities do donate colonoscopy screenings. So if you know someone that is either through diagnostic or not, touch base with that facility that does do screening for colonoscopies, and see if that will be allowable, if they're able to allow a free donation of a colonoscopy, because some of these community members have utilized that.
Great, that's good to know about. It looks like we had a question come in from Michaela. In addition to screening, what about the role of genetic testing for those who have multiple cancers in their family trees? Is that typically an option?
I think in regards to colorectal cancer, and specifically from what I know when it comes to the DNA testing for colorectal cancer, it specifically detects that. So I can't say that for in other cancers in this regards, but with the DNA testing, with the it's a take-home test that you do, and it's pretty accurate. It's almost 99%. So it's different from the FIT testing, which detects the presence of blood, or the FOBT testing. So you're not going to have that issue when you do the Cologuard with the DNA testing. It's going to be specific just to colorectal cancer.
Can you hear me?
Yeah, I can hear you.
I should have been more specific. Hi. I'm very new to this organization. I just learned about it, and I saw this this forum and was very curious about it, because a lot of my family is in Isla Pueblo, New Mexico. But I actually live in Chicago, was born and raised here. And I'm a stage 4 colon cancer survivor, Lynch syndrome related, actually. And but it all comes from my family in Isleta. So I'm particularly interested in, you know, how it affects them and my children. And I'm very interested in helping to spread awareness about early screening and genetic testing. And my survival to this point, over 18 months now, no evidence of disease, is based on a clinical trial at the University of Chicago in immunotherapy with Keytruda or pembrolizumab. And so I'm just wondering, and none of my cousins or aunts and uncles have really been exposed to or been given the option in Isleta to, when I was going through it, to have the same option. They knew that they had Lynch syndrome, but before I did, because Dr. Lynch actually went there in the 90s to study the family, I guess. But I didn't get the memo because my mom had ovarian and we didn't realize that it was related until I went for genetic counseling at 40, thinking I was ahead of the game, but was wrong. But anyway, I was just wondering in general, because we're learning so much about, and it seems like people are getting diagnosed earlier and earlier for whatever reason. And granted, apparently 5 to 10% are only hereditary cancers of colon cancer, but still genetic testing can give us so much insight and can be so helpful in terms of treating. You know, what's the role of that as a diagnostic in Indigenous communities? Is it available? Is it encouraged? Is it talked about? You know, where is it in the conversation, I guess, is my concern.
I'll do my best to answer that, and thank you for joining us today and sharing. You know, and working on this project with NCI. You know, we're teaching about Lynch syndrome, and we're teaching about the role it plays in colorectal cancer. But to actually hear somebody's story is very significant. So I wanted to thank you for joining us today, providing perspective. I'll speak on behalf of my community. It's very low. It's very low in terms of priority in our communities because of co-occurring conditions and managing those conditions and limited resources. Genetic testing is, as far as I know, has been a conversation that hasn't really existed. And one of the areas that I've been interested in is looking at these biomarkers, including genetic counseling and epigenetic markers, and identifying those, because oftentimes they can predict disease much, much sooner than a screening exam can. We know that if you do have Lynch syndrome, that you are at a higher risk for colorectal cancer. With that being said, we also know that the environment and the interaction between the environment and these susceptible genes are very alive. And if we can intervene earlier, if we know that you are susceptible or you do have Lynch syndrome, or Huntington's disease is another good example, we know that there's many, many things that we have influence over between our environment, our behavior, our perception, our spirit, oftentimes actually, that can support those genetic alterations so we can stave off any disease such as colorectal cancer. That's not a discussion that's being talked about and honestly, I think it's a conversation that's typically talked about in the confines of a research clinic, but at the level of our Indigenous communities who are just trying to provide basic care to ensure that somebody doesn't end up hospitalized, or they go to their dialysis appointment, and how do we provide resources for this individual, such costly procedures, that it's just not talked about. And it really is unfortunate. And because, like you had mentioned, this could provide potential insight to not only yourself, but your entire family, if we all need to be tested. And therefore, and then most importantly, what can be done about it? And oftentimes I hear sit and wait. And I think it's a very unacceptable way to look at health. And somebody has an early marker for, say, prostate cancer, for example, their PSA levels are elevated, and it's a sit and wait situation. Well, that's probably not the best. That's probably not going to end up very good. So I'm of the opinion that if we know answers earlier by doing genetic counseling, we test epigenetic markers, and we look at the entire epigenome, we can probably see some pretty good indications of how the individual can be supported. That's a very advanced way of looking at someone's health. And I just think that we lack that infrastructure to be able to provide that kind of cutting edge care. I do believe it is of the future. I forced my way into getting genetic testing at my clinic because I was having a myriad of problematic health symptoms. And I have this very strong family history of many, many diseases. I'm going on the list of diseases that I've seen repetitively come up in my family. So I wanted to get tested for a few different markers, and I had to really fight for that. But I advocated for myself. And so I think that at the end of the day, one of the best and most important ways that we can push that agenda forward is being proactive, is taking ownership over our health, reading, listening, researching, And unfortunately, that burden is often placed on the individual when what we really want is for that provider to give us that type of care and support. Unfortunately, I just think that this medical system in general is overburdened by many, many sick people. And if we can have these conversations, and then the next person has a conversation with their doctor, and they have a conversation with their family members, and we keep pushing that agenda, we force the medical system to change around our needs, then it will, like it often does. I hope that answers your question.
And just to kind of touch base on that, you know, that's the same thing that we're experiencing as well, Will, within our community. We just don't have, you know, that type of infrastructure or that type of knowledge. Now, being out in different communities, it is a little bit different. You know, you get a lot of different community members that will, you know, take for instance, say that they have the same kind of family genetics that you mentioned, or there's another one in North Dakota we're at. There's a family where you get all of them, every one of them will develop a type of like familia adenomatous polyposis, like where your colon develops so many types of polyps, and where you're going to be getting diagnosed, it's basically 100% chance to where you're going to develop colon cancer before the age of 40. Now, that's scary for these people to hear, and a lot of them don't know that. They don't know that with their family history. And I asked, you know, do you know your family history? And some of them are kind of hesitant on asking that, and I hate asking that to a community member, because I don't know their history. I don't know where they come from, their background. It's almost, in a way, it feels like it's insulting for me to ask that, because some of them have said, well, I don't know because I've been adopted, or I'm, you know, you counteract those different types of things within these tribal communities. So it's a little bit of a challenge. It's a little bit of a challenge to, you know, just tell them you need to know your family history. Well, some of them don't. So I think that, you know, in the near future, that needs to be brought up. That needs to be, you know, spotlighted, you know, that genetic type of testing for sure.
I was going to mention a little bit at ACAF that we do talk a little bit about genetic testing, but also do a lot. We actually do have a really strong survivor advocate here who has Lynch syndrome. I can drop the link in the chat to his story, but he is a very strong proponent and wonderful speaker and advocate in our community for discussing some of this. And he might actually have a podcast on our website somewhere that I can try to find too. So we do have some of that, and it's always really enlightening to hear him speak about it, because he talks about how it really runs in his family and how he has these conversations with his other relatives. And then there's another elder man in the community also who talks about like family history, and he has 2 younger sons, and so it's nice to sometimes hear like the dialogue that he has with his sons. So hear a little bit, but I appreciate you sharing your story and bringing it up, and just kind of driving home, I think, for all of us that it's really important to have discussions about Lynch syndrome and genetic testing. So thank you.
Sorry, guys, my camera just keeps going on and off, which is not unusual for my team to know. I think that was a great discussion. One of the things I wanted to ask, because I think, was it Will or maybe Lindsay who talked a little bit about IHS. I think that sometimes there's this misnomer that because IHS is helping with support, it's enough for prevention strategies, for cancer prevention control, for chronic disease prevention and control, and that somehow really like it's quote unquote covered through IHS services. And I think that, you know, as I've worked with more tribes and folks in this area about like resource, I guess with that sort of interplay in terms of what's needed, what IHS and others do help provide, or where priorities lie, where would you say that screening, and particularly colorectal cancer screening, fits within that sort of funding mechanisms and some of the things that are currently funded within the tribal health organizations?
It's important, but I think the key, and from being a nurse is the education. It's just not there sometimes. There's not time. There's so many different things that need to be addressed. So it is kind of like, you need your fit test, here's the test, and here's a little piece of paper to tell you what to do. So it's really not, at least from my experience, there's just not enough time to really do that education that needs to be had. And so that's kind of what I'm seeing is the education piece is missing. It's there, but it's not to the caliber it could be.
And just to kind of go on the topic of the Indian Health Services, a lot of them do a lot of exceptional work and a lot of them are underpaid, but they have to stick with the regulations and the guidelines within Indian Health Services, especially when it comes in regards to patient referred care. A lot of these have to be categorized either diagnostic or preventative colonoscopies. What can be covered under patient referred care? Are they within the CHISDA area? So, and that has been an issue in our territory is, are they within the CHISDA area? If they're not, can they be covered? Is this diagnostic? Is this preventative? So I definitely think a lot of those things those issues need to be presented, and a lot of that needs to be reviewed over.
Great. So Mike, I know, and Misha, I know that we're almost at time. Do we want to wrap, or I know that Reese had asked me to say a few words. This is Andy, but I want to make sure that I'm not doing that prematurely.
I wanted to answer a question really quick. I know Debbie had asked a question, and she was wondering, she works with men in groups, and she's having a hard time with them opening up. So one thing I did in my previous position is I worked on a CDC grant for cancer prevention. And so I would do wellness events, and I was noticing I was having a hard time getting men to attend them. So what I did was I had an incentive for their significant other to bring them to the event, and they were all having a blast and really talking. So it might be an idea is to include their significant others. That seems to really help kind of open the conversation up and like, hey, you need to get your fit test, and the wives or the partners would be like, you need to get this done. And it worked out really well. And it allowed people time to really, have that conversation. So that might be a strategy for you going forward.
I agree it may be, but what I was speaking to is even in a room full of men have a hard time talking about their PSA levels and things that are body parts that aren't working or sizes of implants and all that kind of stuff. They have a hard time even talking with each other in a room full of men.
One thing,
Debbie? Oh, sorry, go ahead, EG.
Okay. So one thing that we've noticed historically through our program, we've always had women that were the patient navigators, the one that talked about, this type of thing to men. Men didn't feel comfortable. And even though like there were men, you got to have a champion in your community. And this is based on what I've seen that worked well. You got to have a champion within your community or within your program who is a male, who will develop the conversation and have those people, you got to have someone open up in a way that no one has really opened up before about colorectal cancer. So whenever I go out into these communities specifically, I will talk to these men because historically I've known that men don't feel comfortable talking about colorectal cancer. They don't like to get screening. But if you have a male that is able to open up that dialogue, to be able to have them open up, from what I've noticed, men will partake in that and start opening up more. And even, when no one's looking, they'll grab the screening and, head home with it. So it's just all about having that champion male within your community.
I agree 100%, Eugene. That's basically what I was going to say, is that that's really critical. And I've seen many non-native female educators come into a group of men and try to have these sensitive conversations, and they're met with a cement wall. It doesn't go very far. And I think most men, I would be pretty uncomfortable, I think, too, you know, and so having that community champion, and I've identified several for that particular purpose, to invite with me to have these conversations regarding various types of cancers, because I haven't experienced myself, but they certainly have. And as an Indigenous man talking to other Indigenous men, those conversations often develop quite quickly. The room usually opens up and men start to talk about that, or they pull you off to the side and say, you know, I'm having a problem. Is there anything or any resources that you can help me out with? And that's, of course, our job. And as the Center for Indigenous Cancer Research, our primary focus, and we've had several interventions now, research interventions to do exactly what you've just mentioned, Debbie, which is how do we help Indigenous men who typically they're just typically not as engaged in their health as Indigenous women. And I think men as a whole, regardless of your background, are less prone to have these conversations with their provider, especially if they don't trust their provider, if the provider is not male. And one of the ways that we addressed this was, first, we took Eugene's advice and we found community champions to bring to our educational interventions and our educational programs, because we were unable to recruit Native men to our programs. As a Native person, inviting other Native people to your program, you think they would come in droves, and it just wasn't the case. And so we recruited our local community champions, and we went to the men. We went into an environment they were most comfortable with, which in this case was a sporting league, a league where all the community congregated and they felt most comfortable. They brought their families. We actually did a locker room talk with them, you know, an area where the men got together, and it was a little strange at first, but what ended up happening was a really great program, which we're actually writing a paper on that program now to hopefully help other communities who are struggling with that same with the same type of issues, is engaging Native men in these conversations that need to be talked about, but are very challenging. So find community champions and go to where the men feel most comfortable. They probably don't feel most comfortable in a health clinic or a doctor's office, but they do probably feel comfortable at their local community centers, for example, where they all meet and share with their family.
Another thing too is producing education information. So what we have survivorship stories that we push out, but typically we like to utilize men in our survivorship stories. Now we just started the digital storytelling, and that's a platform that we use, and it's a better tool to get the attention and draw more emotion to the audience. So if we have that with males, we've noticed that a lot of males will tune in right away, and it won't break their concentration. So if you're to have someone that's well respected within your community, and typically we had one in the state of North Dakota who is a cancer survivor, and he talked about the process of what he went through of colorectal cancer, how he feared for it, and how he just went ahead and did the testing, got it done, found out that he had cancer, and took the steps, and now he's been cancer free, and he's a huge advocate. He was very quiet. He was a Vietnam vet. He kept to himself, but soon as he was able to beat cancer, that was his message. His message was, even if you don't like it, get screened at an early age. And I think that he drew that attention to a lot of the male crowd. So if you're able to get that type of education information produced out, I think that'll help, as well as having a community champion.
And one of the other messages that I provided with men over the years, and I've worked with men, Native men for a very long time, including myself, is traditional Seneca value was to take care of yourself, was to honor yourself and your family by taking care of yourself. And one of the ways we can take care of ourselves today is to do cancer, is to engage in our cancer screenings. And those are messages and platforms that have been very well received by our communities. If we don't want to do it for ourselves, do it for the future generations. And that provides a very, like we talked about, universal messages that seem to be understood across all backgrounds, all ages, both genders. It's that our ancestors, our traditional Haudenosaunee ancestors, took pride in their health. Their health was a community obligation. So when we were out of balance, we were given all the tools we needed to come back in balance, whether that be the land, whether that be our fellow relatives and spiritual healers. And so when I tell people, I try to empower Indigenous men by letting them know that that their health matters, and that your ancestors would be proud if they saw you taking care of yourself, and you taking the initiative now will help the future generation. And most Native men, I believe that is a very powerful message. And it's a message that I have to remind myself oftentimes as well, if my health gets away from me a little bit.
This was an awesome discussion, and I know that we're at the time that we had allotted for today and a little bit over, but I think it's been tremendous. And sorry, everybody, again, this is Andy, and my camera is just being a little temperamental. But I just want to say a million thanks that I've had a chance to work with Tinka Duran, who was on earlier, and then Misha. I don't know. I know that we haven't worked directly, but with the Intertribal Council of Michigan and team, we're on a couple grants together. And then a couple of Linda Burhan-Stepanoff with NACER's, a good and longtime friend. And so I would say that this work is really aligns with a lot of the work that I do in Colorado and with our navigation work. And then of course with all of the work with Fight CRC. So a huge thank you to everyone who's been on today. I think we'd love to keep the conversation moving, thinking about some good opportunities for campaigns, outreach, additional policy work, perhaps shared grants, and really thinking about how we can address a number of the topics that came to elevate screening rates. But I think moreover, there were so many great lessons learned to think about infusing into the work. So I just want to say a million thanks. And really looking forward to this conversation. And I think we're bringing back some really good ideas to help really thinking about honoring all of the folks that we work with moving forward. So Misha, I'll give you the final word, and thanks a million again for being engaged with us and helping make this connection, and to everyone who's been really involved. So Misha.
Oh, it's a big task. I was not prepared for that. I just want to say thank you to all of the participants and the panelists. Thank you, Lindsay. Thank you, William. Thank you, Eugene. Thank you, Mike. Thank you, Reese. Thank you, Andy, for having us come together to talk about colorectal cancer and Indigenous communities, and to make sure that it's a priority for our relatives and the next generations. I am very honored to be a part of this circle and working alongside all of you and with you. So just miigwech. Thank you.
Good afternoon, everybody.
This was wonderful.
Thank you. Good afternoon, everybody.
Bye.
Thank you. Take care.